Good afternoon. My name is Roman Jaeschke. I'm the editor of McMaster Textbook of Medicine, and welcome to another edition of McMaster Perspective. I have a pleasure of introducing two clinicians and physicians and academicians who together led the development of clinical practice guidelines through the Society of Critical Care Medicine for the recommendations concerning critical care response team or medical emergency team. Maybe I will give you room to introduce yourself over several seconds. Kimia.
Hi, I'm Kimia Honarmand. I'm an intensive care physician working at Mackenzie Health in Vaughan and Richmond Hill, Ontario.
Okay, Randy?
Hi, I'm Randy Wax. So I'm a critical care physician and chief of staff at Lakeridge Health in Durham Region in Ontario.
So maybe I will start from Randy. Even though Randy is much younger, he was my mentor in terms of critical care response team close to 20 years ago by now. Randy, few minutes on history of rapid response team around the world and in Ontario.
Oh, that's great. Thanks, Dr. Jaeschke. So what I'd say is it's been recognized for, as you said, over a few decades that there are opportunities to recognize when patients are deteriorating outside of the critical care unit, to flag those situations and to actually intervene to do something to try to reduce morbidity and mortality, and move the patients into the right clinical setting, i.e. to the critical care unit when appropriate. And a lot of work started in the United Kingdom, some work started in Australia, and certainly in Canada, we were watching what was happening at the same time as we were following a lot of the literature about medical error and opportunities missed to try to save patients. And so there's the data, and then there's the stories as well, the really challenging stories that you hear from patients and families about warning signs that may have been missed by clinical teams without having an organized system to try to prevent harm. And so there's two really important aspects of this. One is detecting when critical illness is occurring, or noting the warning signs when it's going to occur, and then what are you going to do about it? What's the response to try to help? And so Canada, I think, recognized fairly early on, after a few jurisdictions started their early work, and particularly in Ontario, recognized that we really want to help prevent these preventable situations for patients. We recognize that there's evolving data that said that if you looked back after patients deteriorated and said, were there warning signs that potentially told us that something bad was going to happen? In the great majority of cases, there were some signs. And so we wanted to learn from other jurisdictions about, well, how do you detect? And then how do you respond when these sorts of situations happen? And so in Ontario, we started off with some pilot work with two academic hospitals and two community hospitals, introducing what we called in Ontario critical care response teams, although they're called by different names in other places. They're called critical care outreach teams, medical emergency teams. And we did some pilot work where we introduced what were called calling criteria. And those are basically based on sort of single organ signs of something bad happening. So for example, very high or low respiratory rate, or very high or low pulse rate, or blood pressure abnormalities, or acute change in level of consciousness, but relatively simple things that clinicians could pick up at the bedside, particularly nurses outside the ICU, to identify that something was happening. And so we introduced the idea of calling criteria to identify those opportunities for getting some help. And then we created teams, and depending on the hospital in the pilot, initial pilot work, would either be led by a nurse, or would be led by a nurse and a physician, and trying to understand the different team compositions to try to help. So we learned some really interesting things at that pilot work. We first learned that, yes, in fact, we can seem to detect when patients are going to deteriorate, and we can intervene with critical care clinicians coming up to the floors and helping the floor staff either stabilize those patients on the floor, or actually move them to the critical care unit if they need it. We got, with the initial pilot, some very interesting data that seemed to replicate what was found in other jurisdictions, where certainly strong signals of potential for reduction in mortality, signals about the reduction in unexpected cardiac arrests outside of the ICU by looking after these patients and making them better or moving them to the right setting. And what was also interesting with that, with the initial pilot studies, is they actually showed that we were able to improve our critical care resource use, because we were able to prevent admissions to the critical care units, and we were able to actually improve patient status when they came to the critical care unit, so we could make them better faster and get them out faster. So there were actually not only clinical benefits for the patients, but also resource benefits for the system.
Well, I will come back to the quality of the data behind your statements, but I would like to use this opportunity to ask you one more question. You are now the chief of staff of a major institution. If you met your colleague who said, hey, listen, you have this system in your hospital, should I introduce it in my hospital? You have 60 seconds, Randy, to convince him. Forget about the guidelines. I want to hear from you as a clinician.
Absolutely. Well, we know that the acuity of patients in hospital continues to rise. We know the ability to look after those patients becomes increasingly challenging, and we know that our health human resources continues to be challenged, where we get more and more junior staff working in the hospitals. And so we're looking for any way to support the staff outside the critical care unit to manage those higher acuity patients. And so extending that critical care expertise and support outside the walls of the critical care unit, even if it didn't change outcomes whatsoever, the fact that we're supporting junior staff, that they feel more confident in managing patients, it helps us with recruitment and retention of staff. That in and of itself is actually a very important thing. And I know in my own center, I could never go backwards, because nobody would ever allow me to do that, because it's become such an integral part of the patient safety system in the hospital, not only for managing individual patients, but also detecting trends for opportunities for quality improvement and risk in the hospital that requires attention that we wouldn't see and we wouldn't identify without having that system in place. But the added benefits from hopeful improvements in clinical outcome are an added bonus.
60 seconds are up.
Okay, so I hope I convinced myself.
No, you convinced yourself. But it sounds to me that what you put on the first place is quality of life of hospital employees, essentially saying that people feel safer and happier. The question is obviously, and maybe I will start asking Kimia now, when you agreed to be a methodologist on this practice guidelines, how did you want to measure the usefulness of response teams?
So the panel that Randy, Dr. Wax, and Dr. Sabat had put together, we really encouraged them to come up with questions that are clinically important from patients' perspectives. One of the key questions that keeps coming up and kept coming up within the group was being able to answer questions around the effectiveness and benefits of versus harms of rapid response teams versus the activation criteria that can summon the response team to attend to the bedside that Randy was referring to. That was one of the key things that we were hoping to address, that unfortunately, because of the very variable study designs and heterogeneity, we were not able to answer. And it's something that we're working towards hopefully addressing in future iterations of this guideline. But really the key questions for centers included factors like, should we have a rapid response team or a medical emergency team in place? What should that look like? What should be the composition of that team? How do they get activated? How do they know to be arriving at a particular bedside, not another? And those were the key factors that we were looking at, we're hoping to address.
So how would you summarize your observations?
So we reviewed a vast amount of data on this topic, and many of these were observational before-after studies, we're calling them, but really they came from, these were studies that came from the quality improvement initiatives that Dr. Wax was describing. So a lot of centers have similarly looked at before they implemented a rapid response system, after, and reported their findings in the literature. So much of the data that we were able to identify to answer our questions were based on before-after studies. Not a lot of randomized controlled trials. There were a few, but unfortunately not as many as one would hope for this topic. So in general, one of our stronger recommendations was related to having a hospital setting, having a rapid response system that includes an outreach team, a rapid response team that goes to the bedside, and some sort of activation criteria that summons them to the bedside of the particular patient who may be experiencing potentially clinical deterioration. And in that particular recommendation, we do recommend for having such a system in place. But again, unfortunately, we were not able to tease apart which component is the helpful component. Is it the rapid response team, or is it the activation criteria that leads to early recognition?
So the question was how to recognize the deteriorating patients, then having somebody to be called, somebody who presumably can respond and has skills to respond, which would help the patient. Now, your strongest recommendation was, as I was asking Dr. Wax, was to implement rapid response team. You didn't say, should there be a physician, should there be a nurse, should it be based on continuous monitoring, should be on vital signs, but you said have this system where people are recognized, there is a communication going to a, so to speak, higher expertise level, and this higher expertise responds without much hassle. Would that be a summary of what you could recommend people who are thinking about it?
Absolutely. I think, our recommendation was based on a variety of models that were reported by various centers in the literature, and all of them had their own, some had a activation criteria that was a single physiologic score, some had multi-score kinds of activation criteria, some had teams that were ramp up, ramp down. So, whether or not the nurse would start looking at the patient first and activate others, versus the whole team would go, including a physician or advanced practice nurse. So there are a variety of models, and really that recommendation captures all of those, all of that breadth of that data. And it really has to be based on that particular center's structure, their needs, their staffing model, their resources, certainly. So I think it's a bit catch-all, but it certainly advocates for the availability of some sort of a resource for bedside staff on the wards to have that ability to access more higher support.
Kimia, do you think would we need more RCTs? Are there doable RCTs in this area at all?
The RCTs that we identified were more, some were sort of stratified, randomizing by center. And so step wedge trials, for example, that we had a couple of those. So it is possible to do trials in this topic. I think where we are at with, certainly in Ontario and certainly in Canada, is a lot of centers do already have rapid response teams. So to randomize centers that already have one to none is going to be challenging.
No. It would not work. Well, we all have our little conflict of interest now. For last 10 years or plus, I'm collecting as part of my professional income from running rapid response teams. So we better tell it to people. When we examined our effectiveness of the team in our institution, the biggest thing was actually, I would say again, on quality of life of staff who felt markedly safer and supported that without those teams. And I believe that would be the reason that there would be a revolution in hospitals if they wanted to take it away. Have you looked at all in how much it costs for whatever benefits there are? Randy, you're probably responsible for major institution. Do you know how people look into finances of it?
Well, I know that when we did the initial analysis, we found that because of the improvement in the ability to use the critical care resources, it was actually a much more cost-effective way of adding critical care capacity. So it was the equivalent of adding more critical care beds into the system because we were able to use the beds that we had at a much reduced price. So even if you didn't even look at patient outcomes, you just said, can you get equivalent patient outcomes in a more fiscally responsible way? It's a worthwhile cost investment because you end up saving resources. And, there's that upward curve of needing critical care capacity. And if you can flatten that curve by making better use of the resources you have, that's a fiscally responsible approach. And at least based on the evidence that we have within the Ontario experience, that investment has been a worthwhile thing. And I can tell you, in a government-funded system and having to ask for ongoing funding to support the teams on an ongoing basis and add more teams, our governmental authorities are quite critical at looking at, the data and the potential benefits. And at least that sort of financial benefit of more resource or better use of resources at less expense, they've certainly accepted that argument, which is why they've continued to fund the teams on an ongoing basis and continue to expand them.
Okay, well, listen, thank you very much for your expertise. Again, your practice guidelines were published through the Society of Critical Care Medicine. I really appreciate you reviewing this vast amount of information, and I think what you produced will help both existing teams and those who will think about whether to introduce them and how to do that. I really appreciate your input and expertise. Thank you.
Thank you.
Thanks for having us.